Good evening, everyone. Acting Vice Chancellor, distinguished colleagues and friends. Welcome to the inaugural Dufferin Public Lecture. I'm Kevin Brazil, and I'm a Professor of Palliative Care in the School of Nursing and Midwifery here at Queen's University, Belfast. First, I'd like to share a few words with you about the legacy behind the Dufferin Public Lecture. The Harriet Georgina Hamilton Temple Blackwood was the first Marquess of Dufferin and Ava. Her husband, Frederick Hamilton Temple Blackwood, was the fifth Marquess of Dufferin and Clandeboye. The Marquess of Dufferin was appointed as the third Governor-General of Canada, and subsequently the Viceroy and Governor-General of India in 1884. Lady Dufferin is recognized as a progressive innovator for her time. During her period in India, Lady Harriet Dufferin launched a program of aid called the Dufferin Fund. Underwritten and promoted by Queen Victoria, the intent of the fund was to bring medical aid to women in India by engaging female doctors from Europe to train Indian women to be doctors and midwives, establishing clinics and hospitals for Indian women. At this time, doctors were male, and Indian women did not have access to sufficient health care, which resulted in higher mortality and deaths due to pregnancy. To this day, a number of hospitals named for Lady Dufferin still exist in India and Pakistan. The present Lady Dufferin continues to link her activities to the values expressed by Lady Harriet. We are delighted that Lady Dufferin has permitted us to honor her and her family by establishing the Dufferin Public Lecture, which will be an annual event run by the School of Nursing and Midwifery here at Queen's University, Belfast. Now, a few words on this evening's speaker. Professor of Social Work and Gerontology, Mary Lou Kelley is located at Lakehead University and the Northern Ontario School of Medicine in Thunder Bay, Ontario, Canada. Her work focuses on promoting interdisciplinary research and interprofessional education in gerontology and palliative care for healthcare professionals. As a researcher, her expertise is community-based health services research. Her honors include being the recipient of the Canadian Hospice Palliative Care Association's Award of Excellence in recognition of her contribution to palliative care in Canada. This was followed by receiving the Queen Elizabeth II Diamond Jubilee Medal for her efforts in palliative care. Today, Professor Kelley will share her experiences with us as the principal investigator of a 5-year program of research to develop sustainable palliative care in nursing homes. So please join me in welcoming Professor Kelley.
It's a tremendous honor to be the inaugural speaker in the Lady Dufferin Public Lecture, and I find it very appropriate and somewhat comforting that we are doing it in the Canada Room, which has been dedicated to recognize the strong ties between Canada and Ireland. And of course, I am here at Kevin's invitation because Kevin and I were research colleagues and did work closely in Canada. And when he came over to Belfast, it was a wonderful opportunity to be invited to come and speak with you here and continue to collaborate. So I'm talking to you tonight about a program of research for developing palliative care programs in long-term care homes or nursing homes or care homes in Canada. Our work has been focused on Ontario, Canada. However, I've just come from London, England, where I was at St. Christopher's Hospice and talking with their research team and practice group that have been working to develop the gold standards framework within care homes in England. And one of my takeaway messages was that our challenges and our experiences are very similar between England and Canada. And so perhaps at the end of my talk today, you can tell me if that's true in Ireland as well. I'm pleased that in the audience we have researchers and students, but also palliative care practitioners and people who work in palliative care organizations. The name of the talk is Knowledge to Action, because the type of work that I'm going to be talking to you about is very practical, community-based type of research that Kevin mentioned in my bio is the kind of thing that I prefer to do. So the project has been called the Quality Palliative Care in Long-Term Care Project, and we were very fortunate to receive funding from one of our national research granting agencies in the social sciences called the Social Science and Humanities Research Council. We also got money from the Canadian Institute of Health Research for the knowledge translation piece, or that knowledge to action piece, so we could be sure that the knowledge that we were generating was made accessible to people who could use it in their work. We have 40 organizational partners, because part of my philosophy is that you need to engage the people who will use the information and the knowledge right from the beginning. And we had a co-investigator team of 10 researchers. At least 2 of these researchers you will recognize. That is me, of course, in the middle. But on the far right, you will see Dr. Kevin Brazil, who just did my introduction. And I just want to say a few things about the research team. On the far left is Paulina Chow, and she is the vice president of the long-term care of a large healthcare organization in Thunder Bay called St. Joseph's Care Group. But why this is important is we had senior administrators on the research team right from the beginning. And about the 4th from the right is another woman in the foreground with glasses. Her name is Janice Sheehy, and she is the senior manager for the 2 care homes in Southern Ontario that were involved in our project. I think that was pretty critical to our ability to be able to really bring our knowledge to action. The rest of the researchers, I'll just quickly go through from left to right. Joni Sims Gould is at the Faculty of Medicine at University of British Columbia. Pat Savine is in the School of Nursing at Lakehead University. Carrie McCaney in the Gerontology program at McMaster University. Myself from social work, as Kevin mentioned. Sharon Kasalainen from McMaster University in Hamilton. I mentioned Janice from long-term care. Joanne Viss from social work at Lakehead. Elaine Wurzma from health sciences at Lakehead University. And of course, Kevin, whom you know. And when Kevin mentioned that I work as part of an interdisciplinary team, I think that strongly is evidenced by the perspectives that we had included in our research group. So here we have Canada, and for some reason the locations have fallen off the slide, but anyway. Here, of course, is Ontario, where I live, and Thunder Bay specifically is right here at the head of Lake Superior. And where Kevin lives is, did used to live in Hamilton before he moved, was down here in Hamilton at McMaster University. And so the project occurred in 2 places in Ontario, both Thunder Bay, where I live, and both down in the Hamilton area, where Kevin was living at the time, and a number of the other researchers are living. I'm going to spend a few minutes talking to you about long-term care in Ontario, or care homes in Ontario. In Canada, long-term care homes, as all health care, is provincially regulated and mandated, so it's not national health. It's provincially mandated. And in Ontario, we have 634 care homes across the province with almost 78,000 beds in those 634. And 97% of the residents who live in long-term care homes are long-stay residents. In other words, they move into the care home because of their quite advanced care needs, and they don't leave the care home again to go back and live in the community. And frankly, most of them leave the care home through death, and that's why this project became important to us. The slide also depicts the sponsorship of the homes. So you will see the difference between the proprietary homes, which are private for-profit homes. In other words, people buy and own and run these long-term care homes as business. Then there's the nonprofit homes that are either faith-based or some other kind of nonprofit group organizes and sponsors the care home. LCAP units are an oddity in our rural areas where there isn't enough of a population to warrant having a care home. They'll fund maybe half a dozen beds in a smaller rural hospital as a care home and call it an LCAP unit. And then 16% of our homes are run by municipalities, so the city, and in fact in Ontario, by law, every municipality must have one care home, and that's to ensure access for residents who might not otherwise be able to afford it, and really dates back to a time when there wasn't provincial health system funding to help residents in long-term care. So people admitted into long-term care homes or care homes in Ontario really do have advanced care needs in the area of cognition. Vast majority of them have dementia. And responsive behaviors is a term we use in Ontario to talk about residents who, because of dementia, have challenging behaviors to manage. And the term responsive is to really convey the strongly emerging philosophy that when a resident with dementia acts out in a violent way or an aggressive way, what they're really doing is responding to either an environment that is somehow troubling to them, it's too noisy, it's too confusing, they're not being cared for in a suitably supportive way. So it's sort of a shift in our language to get away from, so to speak, blaming the resident for being aggressive and rather saying, you know, they're just responding. So, but having said that, again, the majority of residents who are living in long-term care do have and do exhibit these responsive behaviors because they're challenging to be cared for in the home setting, and that's often why they are referred into an institutional environment. And they really are not very independent in their functioning. The majority, 56% of our senior population in long-term care is over the age of 85. So they're really verging on what we call the old. The majority of them, almost 80%, are single, unmarried, mostly women. So, you know, Lady Dufferin would be pleased that we're continuing to advocate for unmet needs of women. And they're unmarried because usually their husbands have predeceased them and they are no longer able to manage on their own independently. And almost 60% of them are assessed as having moderate or severe cognitive impairment. And those are Health Canada statistics from 2011. So I talked about the fact that many of the residents die in long-term care, and I could tell from some of the facial expressions that that is your experience as well. In Ontario, about 1 in 5 residents die each year in long-term care. So that's, you know, roughly 20% of the long-term care home population. So that is a significant part of what is going on in the day-to-day work of long-term care. And of the residents who do die in long-term care, less than half of them, but almost half, over 40%, actually are able to die in the home. Now, of concern is the ones that don't die in the home, and typically what happens there is that there is what we call an end-of-life care transfer to hospital, and that can be precipitated by the care needs of the resident. So sometimes there's been some sort of a medical event or a fall, and it's quite appropriate for that resident to be transferred to hospital if there's a pain management issue. But a lot of times in our experience, it's been inexperience or panic on the part of the staff, being unable to really know how to support, or the family is very anxious, doesn't feel confident that the care home staff really know what they're doing, and the family asks for the transfer. What we're really trying to do, not just in the project, but also in Ontario, is there's now a stated policy goal by our Ministry of Health to try to promote dying at home in long-term care where it's possible, and to avoid these unnecessary end-of-life care transfers. In other words, those would be situations where the condition is predicted, it's an expected death, and there's nothing that's going to happen in the hospital that one would think would make the condition reversible. And within that context, we still found when we got started that the majority of long-term care homes lacked formalized palliative care programs. So yes, they did care for these residents who were dying, but they didn't really have an organized and systematic way of thinking about what they were doing as palliative care, and they didn't have additional skills or training or consultation or resources. And in Ontario, and most of Canada, I would say that palliative care really began in the cancer system, then it became established in the hospital sector, gradually then moved into the home care sector, and there's been a lot of effort in the last 10 years to establish it there, and now finally the last frontier is moving it into the care home sector. So is palliative care no matter where you do it? Well, there are some things that will be the same, like the philosophy and the fact that we want excellent pain and symptom management for people wherever they live. But the nature of the context really does make the environment of palliative care quite different. So in the long-term care home context, we have frail 85-year-olds and over living with progressive life-limiting illness, and they may have been living with that progressive life-limiting illness for years. So to begin to try and articulate when that transition begins to take place to more of a palliative approach to care is a challenge, because it's like turning 50. You feel the same way the day before as you did the same after, and all of a sudden something's supposed to be different, and so it's progressive. It's also their home, and it's the home where they will live and most likely also die. So it's different than a hospice unit. At least in Canada, we have freestanding hospices or hospital-based hospice units, and when someone is admitted there, they're admitted there with the intention that they know they're dying, and this is going to be the place where they choose to get their care, their end-of-life care. But when people enter a care home, they're not dying, they don't think they're dying, they're not thinking about dying, and so we want to promote quality of life and activity and rehabilitation and all of those things in a subtext where we know eventually those care needs will change. It's also, in Canada, a heavily inspected and regulated system. So even though we're working very hard with care homes, they have funding from the Ontario Provincial Health. 80% of their funding is for nursing care and food. That is non-negotiable, so there's no dedicated funding for a palliative care program, and very little opportunity to kind of work around the margins. with the regulations and the requirements they have. The other thing that's different about care homes in Canada, and I think it's probably true, was true in England as I learned, is the vast majority of the staff are not regulated healthcare professionals. They're not nurses and doctors and therapists. They're what we call personal support workers, or you might call care aides, or nurses assistants, or healthcare aides. There are different kinds of terms that are used in different places, but they are usually in Canada people who have finished high school and taken a course of somewhere from 6 months to 12 months, depending on where they go. They learn basic personal care skills, feeding, dressing, bathing, social support, but they are not regulated healthcare professionals, and they are really doing the work. And one of the things that you'll find in a few minutes that we have done quite differently is really emphasize the importance of that role and really focusing on them. Another thing, and I mentioned minimal physician involvement. In Ontario, the physicians usually visit the home weekly, once a week, and will do rounds, but are honestly not that involved in the day-to-day care of residents, which is unfortunate, and we hope we can change. And long-term care homes in society are not really thought of as a place where people die. They're not thought of as a place where you can get palliative care. So that's something that is an obstacle. And they're not integrated well with other palliative care services. So that's a little bit about how we started and why we started. Here were our goals: to improve the quality of life for residents who were dying in long-term care, to develop interprofessional palliative care programs because we felt that was the way to do that in long-term care, to create partnerships with community organizations and researchers to support the care homes in doing that work, to ultimately create a toolkit of innovations, resources, information that could be shared nationally or internationally with other care homes, and to really promote the role of that frontline, unregulated care worker in palliative care, because they were going to be crucial to the success of the work that we were trying to do. Our research design was what we called a comparative case study design. There were 4 homes in Ontario, and you'll see them depicted there. On the upper left is Bethany Nursing Home, and Bethany has 110 residents. And below that, on the lower left, was Hogarth Riverview Manor with 96. Top right was Allendale Nursing Home with 200 beds, and Creekway Village with 144. Now, one thing that I noticed in England that was different was many of your care homes, and I visited 2, are much smaller than that. And we actually are on a trajectory, which I'm not sure how I feel about, to mega homes. In this community where I live, they're closing 300-bed long-term care homes and building 1 410-bed long-term care home. Now they're going to design it with, residential pods, and it'll be created, in small communities. But it is a bit of a challenge to create that home-like environment when you have such a large organization. Granted, the efficiencies, I understand, can be accomplished with staffing and things like services. Well, how did we do this work? Well, we picked those 4 long-term care homes to be our study site partners, and really we were very, very particular that they needed to know that they were making a commitment to doing some fundamental organizational change over a sustained period of time. 5 years was the project. And participatory action research, I think the simplest way to think about it is we work from the inside out, not the outside in. And a lot of times researchers conceptualize their research or have their best practices from the outside and try to bring them into the home. What we did was we went into the home and we said, well, what is going on here? What are the problems? What do we need to do to make it better? And we worked from the inside out. The other thing we did was we worked from the bottom up and not the top down. And often when you try to implement best practices or guidelines, management implements them from the top down. They get adopted, and we know in the literature what a poor rate of uptake there is on best practice guidelines and that sort of thing. And it really is because things don't get filtered down from the top to the front line very effectively. And there's not always an appreciation of what the implementation process will require in terms of changing the fundamental culture. So in this way of working, inside out and bottom up, we really partnered with the staff and partnered with these community partners that I described, who were palliative care experts, like many of you in this room, consultants, and the researchers, to really kind of co-create what we hoped would be this toolkit that would be practical and be very doable. We were very systematic in our approach. In year one, we did a comprehensive environmental assessment of the 4 care homes. We did it by talking to residents, families, the physicians, the frontline staff, the nurses, spiritual care, social work, recreation, dietary, even housekeeping and maintenance and volunteers. We wanted to really understand from kind of an ethnographic perspective what was really the culture and environment that we were dealing with. And we also were able to then understand the facilitators and barriers to moving forward. We next then, using this bottom-up capacity development way of thinking, had the home create their own interprofessional palliative care teams. And they chose who would be on those teams, but we did really guide them to the importance of not just having it registered staff, but the importance of including the frontline staff. And then these teams began to identify things that they felt would be effective in changing practice in the home, would improve care, would better support families, would better provide education based on the results of our assessment. Then for the next 2 years, we really worked on what we called the intervention phase. But by intervention, we mean strategies for change. We don't just mean clinical interventions. In fact, most of our strategies for change were in the area of organizational policies, procedures, education for staff, communication tools. And I'll talk to you about the specifics of these in a few minutes. But they were all about quality improvement and things that the staff identified were standing in the way of them doing the kind of care that they wanted to do. And then in year 5, which we're just wrapping up now, we're pulling all this together in what we're calling this toolkit that can be shared with other homes as a resource to get them started in developing their program. And we're working really hard in sustaining the importance of the work we're doing through doing things like working with Accreditation Canada, who accredits long-term care homes. And they now, as a result of our work, have implemented 5 new accreditation standards in palliative care for the long-term care sectors. So we're very pleased about that, and I like it because it's a pull, not a push. In other words, so much of what happens in long-term care is compliance. And somebody comes around and says, well, you know, you didn't do this, and slap on the wrist. And whereas accreditation feels to me like a much more positive kind of energy. I'll talk more about this stuff because I'm conscious of the time, so if you want to, but these are all the data collection instruments that we used in our environmental assessment. We used a lot of surveys to look at things like attitudes towards care of the dying, organizational culture, staff empowerment in the workplace. One of these surveys is Kevin's. He developed it and used it. It's called Family Perception of Care, and it's family satisfaction with care after a resident has died. We also collected a lot of focus group data through multiple focus groups with all of the different kinds of groups you see, and did interviews with people. So we were very, very thorough in really trying to understand what was going on. And we talked, as you can see, to hundreds of people. But you'll see these personal support workers, or the frontline healthcare aides, That's the most we talk to, because they do most of the care. And if we didn't get it right with them, I really didn't feel like we could do anything different. We talked to about 180 professionals, licensed nurses, support staff, and administration. And I'm pleased to say residents and families are consumers over 100. So, and these were from the 4 homes. And not that we didn't really value physician input, but we only were able to corral 2 for an interview. So this is a very quick highlight of some of the qualitative things that I learned from the data. And these are quotes from the frontline staff. And when I asked the staff, well, what is it that you want residents and families to know when they come here? They said, well, we want them to know that we will care for you for the rest of your life. It's not that you're coming here to the home and you'll only be here for a certain period of time. We want to be able to tell families that sooner and better. And they also said, and this isn't up there, but like I say, 1 in 5 residents die, and they said death is part of the job. That is what we do here. And it's hard to watch people die for a living. And these are people that they often care for a couple of years. They develop very close family-like bonds. And it's really hard for them. And they really needed a lot of support in doing the work. And it really had, there'd been a real strong death denial in the long-term care home. It was just never talked about. And I learned that residents are not like paperwork. So when that came up, I would say to them, okay, well, you've got a problem here. We should get together and have a meeting and sit down and figure out what to do. And they'd say, Mary Lou, residents aren't like paperwork. We can't just set them aside and go and talk to you and have a meeting. So the busyness and the real tremendous amount of tasks that need to be done with a very minimal amount of staffing makes it really challenging for problem solving. And then the last thing is, you can't regulate humanistic care. It frustrates me a lot that every time we have a terrible example of elder abuse or some kind of neglect, the response is, well, let's make another regulation and ramp up compliance. And I'm thinking, that's about the last thing we need. Because if you really try to get under what the root of that is, you're finding a lot of untrained, unsupported people who are probably doing the best they can. And you really need to think about how to approach that differently. And that's what we tried to do. The personal support workers that we talked to didn't feel they could influence change. They didn't feel like they had any opportunity to be involved in palliative care at all. They knew the residents well. They often knew their wishes. Nobody asked them. It wasn't documented. They didn't really have a clearly defined role in palliative care. Having said that, they were very resident focused. They were very committed. They wanted to care for them for the rest of their life. And there was a real strong sense of team amongst this group, which did not, by the way, include the nurses. What the families told us is they really wanted their family member to die in the long-term care home if they felt that the home could manage, if they had the resources and the education. They really wanted more open communication. Families would say, well, we think, our father's dying, and we want to talk to the staff, but nobody will talk to us. They all avoid it if we ask them, or they say, go to talk to someone else. So there was really a discomfort level and not enough opportunity for conversation. Families wanted to be part of the team. They really recognized that the staff were doing the best they could and often felt really reluctant to what they would call complain or cause more work for the staff by asking for a meeting. And they were very receptive to having community partners assist, like hospice volunteers. The physicians that we did talk to talked about them seeing their role as providing comfort to the residents, families, and staff. They really saw the importance of improving communication at all levels and really wanted the residents' and families' wishes a priority. They really recognized that so many staff weren't comfortable with the emotionality of death and didn't want to talk to families and residents, and often either avoided it or referred the families to the physician. They didn't think there were lack of resources and training for the staff, and that there needed to be a lot more information and support all the way throughout the system. In Canada, the physicians receive a stipend to visit the residents in long-term care, but they don't work for the long-term care homes. They're independent practitioners, so maybe 4 hours a week is devoted to long-term care. So they don't see themselves as responsible for the solutions, but these were their perceptions of some of the issues. So these were some of the challenges. And as I say, it wasn't clinical stuff that we really started with, because those weren't the pressing issues. It was training. It was communication, were problems at all levels, between staff and families, between physicians and staff. Marketing, how do you talk about having palliative care as a place of life and a place of death and a place of rehabilitation and a place of palliative care? Like, how do we find the right words to make that comfortable for people? Everybody wanted more opportunities to talk about their wishes, and advanced care planning that was not just medical legal, but much more broad to include people's cultural, spiritual, and social wishes. We weren't doing a good job of identifying when residents could benefit by palliative care because of this progression, and there was a lack of policy and funding dedicated to it. So we entered the PAR process, as I described, with the staff, created ideas, tested them, evaluated them, and then went on to the next. So we went through a cycle of creating 40 some odd innovations or interventions over the course of 5 years that the staff in the 4 homes felt would contribute to helping them do their work better. And really, in the process, I think, tried to create a better critical consciousness amongst the staff about their own vision of palliative care. So here's an outline of our framework, and I'll go through each aspect of this framework, but it starts out with a philosophy and a program description, which were absent in the home when we started. They didn't have a written philosophy or program description, and we spent a lot of time articulating that organizational culture change process. And then we created all of these diverse tools, modules, in-services, innovations, strategies that the homes felt could help them with their direct care, provide education, and strengthen the community partnerships. In terms of the philosophy, and I'm not sure of exactly how you use your terminology here, because I know it's not standardized everywhere, but we talk about a palliative approach to care as kind of being the bigger thing than end-of-life care, and that it's probably when death would not be unexpected in the next year. It's the philosophy where someone is sick enough to die but not necessarily dying at the moment, and you want to begin preparing and thinking and advanced care planning and educating. And the idea is not to frankly leave everything to the last minute when then everybody gets panicky and these unexpected and unnecessary transfers to hospital often occur because people haven't been prepared. And the end-of-life phase is the shorter phase. It could be six months or less, but more typically it's days or weeks. And the focus then is really on what I would call actively dying, where you're really focusing on the comfort and dignity of the resident, making sure the pain and symptoms are controlled and really supporting the family. But all the big work to make that happen has to happen earlier. And that was something that was really a new idea for the long-term care homes, because they were really trying not to talk about it until the last minute. And this is a figure that we've adapted from the Canadian Hospice Palliative Care Association that just helps depict how we're trying to help them think about it. So if a resident is admitted here and they live for 2 years and they die, the recognition is that on admission, on admission, most of the goals of care are going to be in the restorative or rehabilitation area. But right from the beginning, if you acknowledge that we will care for you for the rest of your life, there's the beginning of the recognition of a palliative focus. And then over time, let's say that's 2 years, the goals of care gradually begin to shift until they become more palliative and less restorative. But it never shifts 100%, because living and dying are always coexisting, in a setting like that. The other thing that is important is that we do have the bereavement phase on there, and that was a phase that was being totally unrecognized and unsupported. When does palliative care begin? When you have a resident with a chronic progressive disease. A tool we use in Canada that's been very helpful, developed at Victoria Hospice, is called the Palliative Performance Scale. And it rates it's a functional scale from 1 to 100%. 100% is me, 0 is dead. And so this is, say, restorative care. This is end of life, and this is sort of the palliative transition phase that you saw in that other diagram, where the goals of care are beginning to shift. And that's when somebody, let's say, is at 50%, so they mainly sit or lie, they don't ambulate, they're unable to really do anything, their disease has progressed to be extensive, they need considerable assistance, they may be eating, but they may not be eating as much, and they may be full cognition, or they may be confused. And then it just starts going down from there, as you can see on that diagram. So that was helpful to the staff. The philosophy of palliative care that we helped create for the care homes is very consistent with what they call person-centered care, resident-centered care, or in the dementia world, they're adopting a philosophy called relationship-centered care. At the end of the day, to be honest with you, it's all the same thing. And one of the things that was really important to get staff thinking about is palliative care isn't something extra that you're going to do, something different that you're going to do. It's about thinking about what you already do differently. And that was easier said than done. But when you talk to them about doing these things, they were very comfortable with that. What is the palliative care program? Well, the palliative care program had then formalized, established goals of helping the resident die at home if at all possible, to meeting their physical, social, psychological, and spiritual needs. And we set out in the formal program description all of these definitions that I've already talked to you about, the definitions. And the policies and procedures related to things like how do you create your palliative care resource team? And it's a resource team, not a clinical team, because everybody that does clinical care, it's not like different people do the care. The resource team is a leadership team, a team that really works with management to make sure that all the organizational processes are in place and supports their colleagues on the front line. How are we going to identify when a resident would benefit by a case conference, a palliative care consultation? Will you use that palliative performance scale, or will you do something different? But there's got to be a way to do it. How will we ensure the pain and symptom management? What tools are we using? What consultants are we using? How do we make sure that the grief and loss is supported? Who does the advanced care planning? When do we initiate it? You know, really formalizing all of these things in a policy. We also, from our work, created what we called a self-assessment tool, or a self-assessment audit. And we created a list of all the organizational structures, processes, and outcome measures that we felt would be helpful to a home. If they wanted to develop palliative care, they could go through this checklist themselves with their team to see whether or not, where they were at. So, for example, the first one says that the home had goals and objectives for a palliative care program. I mean, do they have those articulated or not? And so when they didn't have these things, then they could begin to discuss how they needed to begin. The change process in the home is the other thing that I want to spend a little bit of time on, because I think it's critical. And I just, as I said, came from England, and I know they've just been in trouble with their Liverpool care pathway. And I understand exactly how that happened. And the problem mostly, and my colleagues that I talk to feel the same, is that the tool, it has to be implemented by well-educated, well-supported staff who know how to use the tool in an organizational culture that is comfortable with it. And if you just give people a tool and they don't know how to use it, like anything else. So I think this change process is key to the success of anything that we do. And first of all, you need a sponsor for the change, and in the case of a care home, it would be the manager, a senior manager in the care home has to say, I want to do this, I think it's important. And then you need a facilitator amongst the clinical team. It doesn't matter if it's a nurse or a life enrichment aide or a personal support worker, but somebody who will chair meetings, meet with the staff. You need a champion or a lead amongst those frontline care workers, because they are so critical. And then you need to form this team that is going to really become the hub of change. Why the PSWs? And I already talked about, just basically the fact that their role is so all-encompassing, and when we actually articulated it, they do a lot of work with care of the resident, but they also are managing ethical and legal issues. They're advocating for the resident. They're communicating with the registered staff. They're doing time management, supporting the family. So their role is really big, and that's in Ontario kind of shows the proportion. So these are some of the roles that our frontline staff have now been given, and they really celebrate this. They now feel like they can take their seat at the table and they can say to the nurses, this is what we do at the bedside, and this is how we can contribute. So in each home then, the toolkit for the change process that we're recommending is starting on, it's a 3-year change process. It's not the quick fix that some homes would hope for. But we start with this program launch, and the program launch requires that the sponsor or the manager really make an organizational commitment to change. We get these other people in place, the lead PSW and the facilitator and the team members, and then you build your resource team and you complete your self-assessment. And we did that through organizing a retreat. And in the retreat, they identified 1 to 3 kind of priorities. Then we moved into education, and then the teams were in a position now from our toolkit to choose the things they wanted to do and start to evaluate them and implement them in year 2 and 3. So at the organizational level, I talked to you, we have this self-assessment tool. We've articulated the personal support worker competencies, or the competencies of the frontline worker. We've got a grief and loss post-death debriefing module where the staff are assisted in a peer-led process to have a huddle after the death of a resident, and kind of based on trauma research go through a process of self-care. Outlines for retreats, and process mapping is quality improvement processes where they can really begin to understand what's happening in the home now. We've got tools and resources for advanced care planning and guidelines for conversations, pain identification and screening so that frontline staff know what to look for when they see a resident, let's say they're bathing a resident, and their behaviors can be interpreted as indicating pain. I showed you the palliative performance scale. We have multisensory rooms that we've provided training for staff to use for residents with dementia. talk to them on how to use music, social history, creative bedside interactions. What those are is recreation things that can be done at the bedside, so that residents who aren't capable of getting up and going to a regular recreation type of program can do it. Communication was a big one, and I'm going to give you 2 examples from that list because I'm recognizing I'm running out of time. But the frontline personal support workers complained that when a resident died, nobody in the home knew. Even though they emailed people, they made notes, it seemed like it was very hard for the staff to become aware. So they came up with this little magnetic butterfly indicator that they put on the resident's door immediately after they died as a visual reminder to everyone there about what had happened. The comfort care bag, when the frontline staff said, we feel really helpless when families are sitting vigil at the bedside. We don't know what to say. And so they created this bag with pamphlets about feeding, end-of-life care, signs and symptoms, crossword puzzles, candy, a toothbrush, things that they thought would bring comfort, or if they knew something about the person's religious beliefs or religious symbol. And so these are things that they wanted to make their lives easier and their roles more effective. These are all various kinds of communication tools that I can talk to you more about if you ask me questions. These are all education in-services that we created, all of which are available. One of them that was interesting was the difference between spirituality and religion, because they only wanted to call the spiritual care worker when very often people weren't affiliated with a church. And then the community partners that we worked with were pain and symptom management consultants, and I know there are some in the room, the Alzheimer's Society and hospice volunteers that go in. So how did we, what were the outcomes? Enhanced understanding of palliative and end-of-life care by the staff, and a much more confidence in their work. Staff are now highly motivated to be part of the palliative care program. At the beginning they wanted to avoid it. Now they feel really good about it. We really have strengthened the relationships between the home and the palliative care community in a way that they had not been before. And I think we have really enhanced resident-centered care right to the end of life, and really avoided some of these unnecessary end-of-life conversations, because staff feel really confident about what to do. And we've really empowered those frontline personal support workers to take their place at the team table and really share what they know about the resident, and created better teamwork and collaboration, and created this template for the program. So I'm going to stop here, draw your attention to our website, www.palliativealliance.ca. Everything that I've mentioned is on the website. It's all open access, downloadable. You're welcome to use it or to adapt it to your needs, because we're really taking a complexity theory approach to this, where we recognize that each home has to go through that change process for themselves, do their own assessment, look at what their own strengths are, what their goals are, and then adapt and adopt where they see gaps in their own program. So thank you very much.